Hello everyone. Today I'll be continue my discussion about fungal infection of the lungs part 2. Well, in this the main topic of discussion is about systemic mycosis. So first we learned about the basic concept about what is systemic mycosis. Well, all these organisms, in fact, it's a group of fungi which can lead to systemic infection, including pneumonias. All these they can cause pneumonia, and not only that, they can even disseminate depending on what type of fungal infections this. They are all dimorphic fungi. This is a very important question from mycology point of view. Okay, now out of all these, the only exception is coccidomycosis, which is a spherule, and in tissues, which is not a yeast. So friend, the key point that we got to learn in this particular slide are dimorphic fungi, and the exception is coccidomycosis. Now, in the previous slide, we learned about dimorphic fungi. Let us talk more about mycology of dimorphic fungi. What are they? Now, we call dimorphic because these fungi can exist in the form of both mold and yeast. Point to be noted. That means they have a double role to play. They can in the form of mold, in the yeast also. And this happened. Now, what happened? This occurs in change of temperature. Okay. So when the temperature changes, their form changes. That's why they are also known as thermally dimorphic fungi, because the change occurred due to temperature. That's why thermally dimorphic. In the 20-degree cold, it is in the form of mold, and heat, yeast. The mnemonic is cold is mold, yeast, heat is yeast. So quite similarly pronunciation is there little bit. So now you can remember mold is cold, heat is yeast. Dimorphic, thermally dimorphic fungi. You understood the meaning also. Well, now we come to very important aspect of the pathology. They can form granulomas just like tuberculosis, right? We all know when we discuss about granuloma, it is a necrotic material is there. It is surrounded by the macrophages. Okay, caseous material is there in the center. Together they make granuloma. And we all know that the granuloma formation in TB also. So they also have a fracture-like. But what is more important, this is a caseous necrosis. This point is not known to 99% students. In fact, whenever we talk about caseous necrosis, we always think about tuberculosis. But today we learned something extra, that caseous necrosis occur in systemic mycosis. But there's a difference. They cannot be transmitted from person to person, which is a common feature in tuberculosis. In fact, in TB, they're usually from one infected person to other, but not in this case. So we learned about caseous necrosis, as I mentioned, occurs in TB, and systemic fungi like histoplasmosis or any systemic mycosis is there. So the key word to remember is granuloma formation and caseous necrosis are the two keywords that you got to remember in this particular slide. Well, as I was talking to you regarding pathology of any caseous necrosis, macrophages, wall of the infective organism. In the granular debris, which I mentioned, this is the caseous necrosis or the so-called debris material surrounded by the macrophages. That is so-called caseous necrosis. Okay, so we in the caseation we got fragmented cell and debris surrounded by mainly the macrophages, but little bit of lymphocytes can be there, but mainly by macrophages. Okay. This is a classical thing that we talk about. Caseous material is there. It's a gross specimen to demonstrate to you the caseous material. Now, the treatment of most cases of systemic mycosis is fluconazole or itraconazole. This is for local infection, but we can use amphotericin B for systemic infection also. So that means grossly, in a nutshell, I'm talking about systemic mycosis, amphotericin for systemic and fluconazole for local infection. With this background of basic concept, now I'll be taking individual systemic mycosis. Everyone has a different features we'll talk about. So systemic mycosis, the first one is coccidiomycosis. Now in the world where it is endemic to southwestern US and northern Mexico, in certain part of Central and South America. So by and large, if you see, it is mainly confined to the America or USA or the South America. Okay, let me show you a lovely picture where we can see. Now you can see it is in this part of USA and Mexico and the countries. But one thing, there's a world map is there. It is very surprising that it nowhere else in the world. Africa is totally free, Asia is free, Australia is free, Greenland is free, Canada is free. Oh well. Okay, so something localized. Beautiful picture at a glance with the beautiful white and black background with the color picture of the countries involved. It is very clear to you. In the USA in particular, we talk about, because it's more common in USA type, USA, West USA and California are the area which is very common involved. Well, it can lead to a type of desert rheumatism. Okay, what is that? I'm going to discuss, but lovely picture to demonstrate. You look into this picture. There's one gentleman is there, totally desert area, and this gentleman, I think, is a local way of treatment. I like this picture. I love this picture, so I thought I must share with you. Okay, some local treatment. Just imagine this gentleman only totally in the sand, and I think he's crying with pain also. So called in the treatment of desert rheumatism, which is called by coccidiomycosis. I'll be talking about this, but lovely picture. So now we talk about. Look into the picture. This is the histology picture. Coccidioimitis. Note the spherules containing endospore. This is spherules, and there are a lot of endospores are there. And in the very beginning, I told you this is one exception, which is not. It is spherule. It's not a yeast-like fungus. That is exception, and this is spherules and endospores. Yeah. So now we talk about pathophysiology. Spherules are filled with the endospore, as I shown you in the picture also. And how they are contracted by inhalation. Arthrospore in the dust while living or passing through the arid desert area in the southwest. And that means this fungus occurs in the desert area, as I demonstrated you in the picture also, right? That's why this is known as valley fever is the name, which is given to the fever caused by coccidiomycosis. And it is increased, classical example is increase after an earthquake. Why? Because when the earthquake occurs, no need to say, in the desert area, that due to lot of dust will float in the air. So definitely this dust contain lot of this endospore. So the chances of getting this infection by inhalation route is very high after this earthquake, because the spores in dust are thrown into the air. That's the basic pathophysiology. So friends, the key word to be remembered here are valley fever, earthquake, and inhalation route. So there are only 3 key words that you can remember, and the picture what I showed you initially will really tell you is more common in the desert areas. What are the clinical features by which patient will come to us? Flu-like symptom, fever, malaise, body pains. Erythema nodosum is a classical feature. What are erythema nodosum that we see in many other places like tuberculosis also? So they are, and of course we see in Behçet disease also. So they are not specific to systemic mycosis, the other condition of erythema nodosum. They are, what are the erythema nodosum? They are painful nodules in the lower legs. In fact, they are the inflammation of the subcutaneous fat is there. But in case of coccidiomycosis, we call particularly as desert bumps. Okay, let me show you the lovely picture of desert bumps. You can see, well, it means any person, any medical practitioner in the California area, a patient walks into the OPD. Looking at the legs only, we can make, oh, multiple desert bumps are there. He can diagnose he's suffering from coccidiomycosis. Okay. So desert bumps are seen in coccidiomycosis. But remember, they are nothing but erythema nodosum. They can cause pneumonia. They can cause meningitis also. Point to be noted. So once the organism this enter the body, it can disseminate. The point what I told you in the very beginning when I was talking to you regarding basic concept about systemic mycosis. So it can lead to meningitis also. It can even disseminate to bones also, skin, the point I mentioned to you. Oh, one of the classical feature in this is bony pains, what we call a desert rheumatism, the figure I told you. So it means the lot of joint pains are there, maybe some local practitioner. He's putting the patient into this sand and he say, oh, this sand will cure you. Might be, I'm not sure about it. Well, when it is being, some local treatment are always there. At times they may or may not be effective. Well, as far as our exam is concerned, the keywords are number 1, erythema nodosum, desert bumps, pneumonia, meningitis, bone, desert rheumatism. These are the points that you got to remember regarding exam point of view. Pathology, granuloma with the necrosis, that is a feature of all systemic mycosis. Usually self-limiting, but sometimes we can give in itraconazole or fluconazole, the point which I again mentioned. These 2 points I mentioned when I was talking to you regarding general basic concept about systemic mycosis. Second cause of systemic mycosis is histoplasmosis. This is a very VIP topic, very often asked in the exam. And this is again found in river valley in North and Central America, Eastern and Southern Europe also, a part of Africa, Eastern Asia and Australia also. So it means the distribution of this is little wider than the previous one, coccidiomycosis, which have a limited involvement in the American continent only. Now this occur in soil in area of endemic, because this area, whatever I told you, they are endemic for the histoplasmosis. What type of soil it is? It is acidic, damp environment, okay, with high organic content. Point to be noted, the coccidiomycosis, the primary requirement was desert area. That's why we got dust, earthquake, desert rheumatism, etc. But this need a damp area, okay, acidic area with high organic content, and this is ideal for the mycelial growth, that is good for the growth of the fungus. So the environment differs. So now this is seen in the USA again, with part Mississippi and Ohio River Valley is this. Remember, this was for the coccidiomycosis. Okay. So if you look into the picture, we are getting alveolar macrophages containing intracellular yeast form of the histoplasma. You can see this also, right? So let's talk about pathogenesis. This is the most common systemic fungal infection. I'll be discussing more systemic fungal infection, but this is the most common. Again, inhalation in the dust containing. Now, it comes from where? Excreta from the bats. That's why it is increased in cave explorers. Point to be noted. And second, chickens, common in chicken farmers. So we are getting in this particular area where we have discussed, there are a lot of caves are there, and chickens can also lead to. So this is something unique about caves, explorer, bats. Now I have a question for the students. Okay, tell me which other infection can occur in those who are cave explorer. You get 20 seconds to think and write the answer, and those of you who will be watching the recorded video later on, you can stop the video and write down the answer. Which other infection is common in those who are cave explorer? Well, the answer to this question is rabies. Rabies spread by aerosol also. From the bat, again, a question not known to 90% students are not aware. Everybody knows that dog bite can cause rabies, but many of us are not known that rabies can occur by the aerosol route also, and rabies can also occur by the corneal transplant. They are exceptionally beautiful question for the exam point of view. So we come back. So friends, cave explorer and chicken farmers are the two keywords that you got to remember in this particular slide. Pathology, macrophage are filled with the histoplasma. I showed you a picture also. Granuloma formation with caseous necrosis, that is a feature that we see in all systemic mycosis. And yeast form are present in the macrophages, right? Now they simulate TB. This I think this is the most important line in whole histoplasmosis. The picture of histoplasmosis exactly resemble like tuberculosis. They produce coin lesion, the way we get in tuberculosis. They can produce consolidation. But miliary spread, this is one of the most important aspects. Outer lung lesion also, this is the one, miliary tuberculosis. The patient can have miliary dots are there. And one more thing, extra knowledge for you, when the patient may be true miliary tuberculosis also. Let's talk about true miliary tuberculosis. Patient may have no symptom. No symptom. Symptom means lung symptoms. He may not have any cough, no sputum, etc. No symptom, lung symptom. He may just come with fever only, weight loss. And you do chest x-ray and you incidentally you go for chest x-ray and you find miliary shadow is there in both the lungs. Miliary shadow we get dot, 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 dot. Dot, dot we get in the both bilateral is miliary shadow. But remember, that same presentation may occur with the histoplasmosis also. Cavitation formation can occur. Now you can see all these are just like tuberculosis. Now, but what is extra finding that will really get you, oh, we are dealing with histoplasmosis. First is from which place, which country the patient has come to you. Dystrophic calcification, this is the something unique, much more common in histoplasmosis as compared to tuberculosis. And in fact, most common cause of multiple calcification in the leuka, in the spleen. In the spleen is the place, that means you take abdominal X-ray, you can find, or abdominal CT, you can find plenty of calcification in the spleen. Okay, and look into this. This is the one. Just see, you cannot miss this finding. Just see various calcific focus. Same is so many calcific focus. That's a classical. That's one point which will differentiate this from tuberculosis. Dystrophic calcification, the spleen, you can see. Once you see, you will never forget. So if you are getting in the exam, if you are getting a calcification in the spleen, 99% you are dealing with this histoplasmosis. Okay, so golden line to remember: splenic calcification is equal to histoplasmosis. Okay, histoplasmosis. Splenic calcification is histoplasmosis. Again, one more chest X-ray. Same, you can see diffuse. Treatment, again, it may be self-limiting. If severe, itraconazole, or we can even use amphotericin B also. This what I told you in the very early first slide, the basic concept about systemic mycosis. Third type is blastomycosis. Most cases occur in North America, where fungus lives in soil near the river beds. Point to be noted. So now we have from the desert, from the damp area, now we have come to river beds also. In Africa also it can occur in some part. And now most commonly fishing, do I need to tell you? River bed is there. Hunting, gardening again in the near the river bed, something like that. Dams, exposure to beaver dams. Beaver are the reservoir for the dams, for the fungus. Point to be noted, it occur near any watery area. Well, okay, fishing is the most common. Point to be noted. Don't forget the previous one was in the cave explorers. Right. So now this is the area you can see where we can have the problem. In America, we can see a part of Africa is the one which is there. Okay, right. So in blastomyces, node is formed with broad base buds. You can see buds. Now, if you look into the name, blastomyces dermatitis, the name itself is suggesting that skin involvement will be there. So let's talk more about mycology first before I go to systemic feature. Is with broad base buds and nuclei, the point I showed you here also. You can see broad base bud, the prominent nucleus is very clearly visible here. Granulomatous inflammation with caseous necrosis, which is a common feature of all systemic mycosis. Now the clinical feature, more common in males. What could be the reason? If you look, who are involved, fishing people and all this thing. So, and usually fishing is done more by the males, that's why it's male dominant. It produces skin and lung lesion. The name is itself was dermatitis, that means skin involvement is there. Lung involvement is a feature of almost all systemic mycosis. Skin lesions simulate squamous cell cancer of the skin. Okay, they look like, and the treatment is amphotericin B. Point to be noted that it's more of a systemic involvement. So amphotericin B is the side effect, is the drug that we use in these cases. So now I'll show you, look into this. This is the skin involvement in blastomycosis. Looks like squamous cells. Definitely this case will be confused, but again, history of from which country or which part of the world patient has come, that is always very important. In fact, there are many diseases which are localized to a particular area of the geography. That's why when we take a history, place of residence is very important, and there's nothing to beat the clinical history and examination. The next one is paracoccidomycosis. It produces acute or chronic infection. Okay, point to be noted. Now this is causing acute as well as chronic infection. It occurs only in South and Central America, only again discrete. One thing we have noted that all systemic mycosis are usually confined to this American continent, North and South America. Now who are the, especially coffee grower in Colombia, Venezuela, Brazil? Well, so we are getting some beautiful question. Fishing people, coffee grower, cave explorer, and these are the keywords which will fetch the answer for you in the exam. Again, men in 20 to 50 years. Okay. Now a unique question. It is considered to be a neglected endemic mycosis. This is a very frequently asked question in all the exam. A type of neglected tropical disease, what the actually meaning is, this topic is not discussed widely. So it is just a type of neglected. Everywhere they prefer to talk about coccidio, histoplasmosis or blastomycosis. This is usually not discussed, so-called a neglected type of endemic mycosis is there. But however, the key word to remember are coffee growers. Cannot afford to forget coffee grower. Only one keyword, and neglected endemic mycosis. So you have to remember only two keywords in this particular slide. Now look into this. Oh, look into again a picture, lovely picture. You can see mainly the South American countries and little bit of southern part of the US and Mexico, and all these are the place where it can occur. So now let's talk about mycology. Budding yeast with captain's wheel. Look into this. It's like this. It's like a wheel, and we have budding. They are budding. They look like a wheel, captain's wheel. Keyword to remember. Okay. Well, it is a much bigger than the RBC size also. So what happened? This is a mnemonic to the. Remember, just now I show you picture. It is more common in the Latin American countries. Latin America country that you can see. So what the mnemonic is? Paracoccido parasales with captain's wheel to Latin America. That means with the Latica, Itica, so paracoccidomycosis has a wheel. The name of the wheel is captain's wheel. Or you have a car, of course every car run on the four-wheeler what we say. It has a captain's wheel and it goes to what part? Latin America. The picture I showed to you. You will never forget this picture. Latin America, captain's wheel. Asymptomatic lung infection, sign and symptom. Patient may or may not have any symptom. Perhaps that's the one reason. Okay, in fact, only less than 5% of the infected individuals develop clinical disease. So that's why, since even 100 people have been infected, only 5% will have some feature. That's why it is known as that's the reason why we call it as neglected endemic mycosis, because infection is there but there is no clinical manifestation, so it remains neglected, right? So you understood the reason why it is neglected? Definitely, which is not visible. Anything, the rule of marketing also they say, anything which is not visible is not sold. If everything is visible, that is sold much more. That's the basic fundamental what the marketing people talk about. Here also 100 people are involved, only 5 are manifesting. That also they have what problem can be there. Look into this. So we have two types of presentation, acute or subacute form which occurs in young children. Chronic form occurs in the adult man. So acute, children or young adult, chronic in the adults. Most are infected before the age of 20 years. That means tend to involve more of an acute problem. Acute problem comes fever, malaise, okay. Although symptom may present many years later also. Point to be noted, the organism has entered the body maybe at the age of 10-15 years, but he is manifesting later on. So it means the patient, the organism enter the body, it may manifest immediately, and that is the acute, but it may manifest after many years. That is the chronics, and we know that it entered the body before 20 years. So definitely acute form will occur in the children and the chronic form will occur in the adults or elderly people. Now you understood, you can nicely correlate pathophysiology, mycology with the clinical feature also, why patient has acute and chronic manifestation at different ages. Now let's talk about juvenile or so-called acute or subacute. As I told you, patient has fever, weight loss, feeling unwell together. They're all like flu-like features. Lymph node may be enlarged liver and spleen. Oh, so we are getting hepatosplenomegaly and lymph node are enlarged, and patient has hepatosplenomegaly also. Not to forget, these findings may occur in tuberculosis also. Definitely. TB patient may come with a fever, weight loss, malaise, spleen, liver enlarged, and lymph node are enlarged. And this may often disseminate. And now it's disseminate. So now whichever organ it may involve, the patient will have that manifestation. But not to forget, these are the initial features. And later on dissemination occur the way exactly like tuberculosis also can spread to so many organ, dissemination can occur, right? Well, skin and mucous membrane are often present. That's one thing, peculiar thing about skin and mucous membrane. Bone involvement can occur. This can occur in tuberculosis also. So, in that way, acute may mimic like tuberculosis, may mimic like lymphoma and leukemia also. So various, definitely liver enlarged, spleen enlarged, lymph node enlarged, that we can see in lymphoma, leukemia and tuberculosis. So that's why I was talking to you that it may resemble very closely with various other diseases like this. Adult form is a chronic form. Just to remind you that the infection, the child or early adolescence, the infection was caught. But it may manifest later on what we call as chronic form. Months to years after initial infection, as I just mentioned to you, it comes with dry cough and shortness of breath. That means this gentleman is mainly presenting with lungs feature. Simple shortness, dry cough and shortness of breath, so-called dyspnea. That is again a non-specific feature. Not in particular that it may occur in fungal infection, anything. Well, other include excess salivation, difficulty in swallowing and difficulty in voice control. Oh, this is the key word. Something unique, and here the keywords were TB and leukemia lymphoma. Here the keyword is something related to in the upper you can say upper GIT. Excess salivation, difficulty swallowing, difficulty in voice control are the unique feature which we have not seen. So now by and large you can see every systemic mycosis has some unique thing which will give you a catch point. Here the picture mimicking like again leukemia lymphoma, but again that may happen with histoplasmosis also, but there was dystrophic calcification. Here what we are getting is excess salivation, difficulty swallowing also is a unique feature. So these are the catch point by which you will fetch the answer. Now you look into this, okay? You can see lymph nodes are getting enlarged. You can see the skin lesion are there. Upper respiratory tract mucosal lesion may be present as well as increased mucus production and coughing up of blood also. Point to be noted, the initial presentation what happened in the acute form was dry cough. But when the patient come to you in the chronic form, now he come with the excess production of mucus and coughing of blood, that is hemoptysis. So definitely a adult man come to you with this finding, with hemoptysis, weight loss. Look into this gentleman also, he looked to be quite emaciated. Looks like tuberculosis. Okay, and hemoptysis, the jaw again. One of the important DD of this condition shall be tuberculosis, which I mentioned. So both pulmonary and extrapulmonary involvement is common because it can disseminate. Because pulmonary I mentioned just now and disseminate various parts of the body I mentioned to you. So it has got lot of resemblance with tuberculosis. Well, in 70% of cases, mucosal involvement occurs. Point to be noted, mucosal involvement we have not seen in any of the other systemic mycosis. So the mucosa involvement is mouth, oropharynx, larynx and palate. Now you can explain the reason why he had salivation, why he had difficulty in voice control, why he had difficulty in swallowing also. So now because the mucosa involvement occurs of the mouth and oropharynx. Superficial painful granular ulcer with small spot of bleeding. What we get is this finding. Superficial painful granular ulcer with small spots of bleeding we get in these patients. And that's why a patient has difficulty in swallowing also because painful ulcers are there. Treatment is as itraconazole. Oh, this is something unique. Dimethoprim methoxazole is, remember, this we have not seen in any other systemic mycosis. Okay. So now I'll continue with the pharmacology of antifungal drug also. Amphotericin B is one of the most widely used antifungal drug that we use in invasive mycosis. What the mechanism? It binds to ergosterol. It is unique to fungus. Okay. So it is, that's why it is used only in as an antifungal treatment. And it forms membrane pores that allows leakage of electrolyte. So you can say this the membrane. It makes multiple pores. So electrolyte can leak out. So amphotericin tears hole in the fungal membrane by forming pores. So multiple pores are made. It becomes porous. The fungus become porous. Porous means leakage. Definitely it will leak out. So we use only in serious systemic mycosis, not a routine duct. Cryptococcus is the classical with or without flu cytosine for cryptococcal meningitis, one of the most widely used drug. Because this is very common in HIV patient. So in acute stages we use this. Later on we can just carry on with flu cytosis when the patient is out of the ICU. It used blastomycosis, coccidio, histo, candida, mucor also, and intrathecal for fungal meningitis. So they are all these systemic mycosis I discuss. So systemic mycosis plus cryptococcal meningitis, but this the single most important is cryptococcal meningitis. Important precautions, they can lead to profound hypokalemia and hypomagnesemia, are the important side effects. So that's why these two are very, very important question. In fact, whenever they talk about amphotericin, 99% of the question will be on the side effect. They lead to hypokalemia and hypomagnesemia. That means whenever we are treating a patient with amphotericin B, never forget to supplement with potassium and magnesium, and they can also lead to renal damage. They can lead to, and remember, they can lead to a type of pre-renal failure. Okay, because they alter the renal tubular permeability, so they a type of pre-renal permeability they can lead to. Adverse effect, chills and fever, shakes and bake, is commonly asked. Classical question, the word shake and bake, they use for this. Of course, fever can occur with a side effect of so many drugs, but this is the particular is shake and bake. Hypotension, nephrotoxicity, arrhythmia, anemia, IV phlebitis, again a unique point. So when we are giving, it can lead to severe phlebitis, what we call as amphoterrible. Hydration is reduced hydration can reduce nephrotoxicity. So how to reduce nephrotoxicity is you keep on hydrating. Okay, and one more, nowadays liposomal variety of amphotericin has been created. This reduces toxicity. So if you want that that at least particularly nephrotoxicity should be avoided, give hydration water. And of course, I mentioned to you arrhythmias usually occur due to hypokalemia and hypomagnesemia. So supplement with water, supplement with potassium, magnesium are the way how we can avoid the problem in these patients. So this is important. This is very important. This and these. They are the 4 keywords that you got to remember in this particular slide. 1, 2, 3, and 4, and hydration can reduce toxicity, and of course hypokalemia and hypomagnesemia. Second important fungal disease is azole, which include so many azoles, Vorica, Myco, so many azoles are there. Okay. Well, in this group, all these are antifungal, but I'll definitely like to talk about ketoconazole. So I have a question only for the student to answer. Ketoconazole is a very, very important antifungal drug. Okay. My question is, we use in certain, other than fungal infection, we use in certain systemic disease. Okay, I'll give a clue, we use in certain endocrine condition. Tell me where we use. You get 20 seconds to think an answer. In which endocrine condition we use this drug? Quickly, you get 20 seconds to think an answer. Well, the answer is that we use this drug in Cushing's syndrome also. If you want to see more detail about this point, you can see my lecture on Cushing's syndrome. There I discuss in great detail how ketoconazole is used in Cushing's syndrome. Anyway, as of now, I'll be just talking to you, focusing on my talk on as an antifungal drug. How does it act? It inhibits sterol, ergosterol synthesis by inhibiting the cytochrome 450 enzyme. Point to be noted, it is again causing problem in the ergosterol, but mechanism is by inhibiting cytochrome P450. So, and it is this which this enzyme convert lenosterol to ergosterol, and since they are inhibiting the enzyme, lenosterol will not be converted into ergosterol, and ergosterol will not form. That is a very, very important component of the fungal wall. Local clinical use, less serious condition, systemic mycosis, we can use. There are so many systemic disease we saw. Systemic mycosis, we can use their local. Fluconazole is very widely used drug. It's a chronic suppression of cryptococcal meningitis in AIDS people and Candida infection of all types. I told you that cryptococcal meningitis is very common in HIV patient. Itraconazole we use for blastomycosis, coccidio and histoplasma. and clotrimazole and miconazole for topical fungal infection we use. So we can see different type of uses are there. Fluconazole for HIV, itraconazole for systemic mycosis, and this is for the local fungal infection, especially of the skin. So you can write down fluconazole for HIV, itraconazole for systemic mycosis, and this is clotrimazole for local skin infection. So now I made your work very easy by telling you what places which antifungal we use. Adverse effect are testosterone synthesis inhibition. So this lead to gynecomastia, especially with the ketoconazole. Point to be noted. And I told you ketoconazole we use for Cushing syndrome. Liver dysfunction, why? By inhibiting P450. So definitely it will be more prolonged of the azole or all azole because they are inhibiting cytochrome 450. Thank you very much. God bless all of you.